Hey there, everybody. Thanks for joining us. This is a continuing education webinar on the use and abuse of surgical wound drains. I'm Dr. Steve Mailer, a boarded surgeon in the Philadelphia area. And I'm just going to take you through some of my opinions and experiences with surgical wound drains. We'll do a little bit of history and indications, and then take us through some examples of wounds and when not to use drains and when it's best to use them. So we'll go ahead and get started. So the first topic here is just the simple definition of a drain, and it's any tube or material that's used to remove fluid from a wound to minimize dead space. That definition, although simplistic, is really the only reason why we should be using surgical wound drains. It's to remove fluid to minimize dead space. That's it. There really are no other indications for placing a drain in a wound, and we'll better define that and talk about some of the negatives of using drains. I think the most important part of this to start is that placing a drain of any type, whether it's a Penrose drain or a closed suction drain, is not a Band-Aid. It does not replace surgical technique. It does not replace surgical debridement and lavage and proper wound management at all on any level. These are the things that we would place, again, just to minimize dead space, not to drain infection, not to hope that devitalized tissue comes seeping out. In fact, using a drain in those situations is contraindicated and will absolutely make that wound situation a lot worse. Lots of materials have historically been used for drains. I think we will focus on the things that would be most ideal in a drain or wound environment, ideal drain properties. We want something that creates the best tissue apposition. That's, again, number one indication for using a drain is tissue apposition, minimizing dead space. We want to use a material that's as inert as possible. Any foreign material we're putting in the body has some level of reactiveness, but we'll pick a material that is as inert as possible. We want it to slide between tissue planes so we don't have a lot of discomfort while the pet is wearing the drain. And we want to be able to remove it easily without causing a lot of discomfort. It's, if we don't have to sedate or anesthetize the patient to remove the drain, that would be ideal. And we obviously want something that comes in multiple sizes. This is not a one-size-fits-all situation. We're dealing with little tiny puppies or cats all the way up to the giant breed dogs. So some of the questions that we're going to answer through this webinar are when we should use a drain, why we should or shouldn't use a drain, where do we use them, how do we use them. The typical when, why, where, and how questions will be really the discussion point. This is the philosophy that was in human medicine turn of the century, 20th century. And the idea was that, well, if we're just not sure, let's use a drain. And I feel like that in general, that decision-making tree still exists in veterinary medicine for a large part. And that I believe today is not the way we should be thinking. When in doubt, we shouldn't drain is really what this should look like. Because drains, again, are foreign materials. We can make things a lot worse using them. And if truly our only reason or indication we should be using a drain is to minimize dead space, then I think we use drains way too often as a profession. So should we use a drain? Again, it depends on a lot of things, but when do we use them? Again, dead space is our number one offender. It's the number one reason why we should be placing a drain. If we're hoping to use a drain in this dog, which is a dog that was hit by a propeller out in Lake Michigan, there's a lot of tissue damage in there still. And so if we have not treated that wound appropriately, maybe as an open wound for a little while, delayed primary wound healing is probably the least utilized form of wound healing, and it's probably the safest and maybe most efficient, where we manage a wound open for a day or two. Let's just make sure there aren't other tissues that are dying off before we go ahead and close this. This is a wound that needs some open wound management first. And once we're done with that, we can go ahead and close this. And there's a tremendous amount of dead space there. We're going through skin, sub-Q, muscle, we're all the way down to the vertebral bodies. And although we can close those layers individually, it's probably an area where I would use a drain as long as I'm not worried about any further devitalized tissues or infected tissues. Clean lacerations, the other picture here is a dog that I saw in West Philadelphia from a machete attack. Beautiful, wonderful, sweet pit bull, certainly didn't deserve that. That's a nice, fresh, clean laceration, and that's one that I would not use a drain in. I'd close that up and not have to worry about too much dead space there. Obviously, this is a case where using a drain is going to be very important at some point in time. This is a massive avulsion injury of the skin in a basset hound. And right now you can see we're using tap water, which normally I would not put into a wound except early on if we're trying to remove all of this dirt and debris. But at some point we're going to close this, and we can use a lot of tacking sutures to minimize dead space, but that's a lot of suturing and a lot of foreign material. So a drain would be used in this pup at some point. We have other times that we would want to use drains, bite wounds, etc. And bite wounds are their own topic. Bite wounds are probably the most complicated or complex injury that we see in dogs, bar none. There's nothing else that comes close because there's so many different forces that have created the trauma to the patient. There's the puncture wound, there's the avulsion from the shaking, there's the crushing, and it's the crushing that is most disturbing because those tissues are usually going to declare themselves over the course of 3 or 4 days. So open wound management for sure, and then if we go to close it and there's a lot of avulsion injury and dead space, then I may use a drain there. Again, just examples of when. This was a dog that had a penetrating thoracic injury. Although the arrow looks like it's right through the middle of the heart, it wasn't, very close. And in this case, we have a penetrating injury that could also contain some foreign material. We're going to open this dog's chest just to remove the arrow alone because we have really no clue where this arrow is or is not. And then we're going to flush the chest out. And so obviously a chest tube is a form of a drain, but we're going to focus more on the external wounds in this webinar. So when should we drain? It is case dependent. There's not a simple answer, but I will say that if your reasoning for choosing a drain is to minimize or mitigate dead space, then you're making a wise decision. At least we're using it for the appropriate reason. And doesn't mean that every wound that has dead space also needs a drain. And so it is a case-by-case decision-making tree. And there's other ways to control dead space. If the wound or dead space that you're trying to minimize is on a limb, I'd much rather use a nice compression bandage than place foreign material into a wound. If it's somewhere else on the body that's more difficult to damage or bandage, then yeah, I may use some suturing techniques, some tacking sutures, or I may use a drain in a case like that. So again, looking at bandages and tight neoprene wraps and these tacking sutures or walking sutures that are described here in these pictures are really good ways to deal with dead space. Again, where I don't like using tacking sutures as the only mechanism to control dead space is when I'm going to be putting 100 pieces of suture in a wound. That level of foreign material and potential tissue reaction may be worse or as bad as using a drain. So maybe I use 20 tacking sutures and a drain, or 20 tacking sutures and a bandage. Lots of options for controlling dead space. Why should we use a drain? I think the answer is going to be the same to most of these questions, is we need to make sure that dead space is well under control. Not even so much for the potential infection that may ensue with a lot of wound fluid, but we want these things to heal. We want these tissue planes to be opposed. And so if there is separation of these soft tissue planes that normally shouldn't be there, the only way they can heal is if they're opposed again. And if there's a lot of fluid that's sitting between them, it's going to take them a very long time to heal and to seal back together. So when we use the term dead space and tissue plane adhesion, things of that nature, we're really trying to accomplish the same thing. When these seromas form between the subq and the muscle layer, especially, or between the subq and the skin, again, this separation of tissue planes occurs, and we need to make sure that we can get those tissue planes back together again. And so suturing is what we're good at. That's what we do all day long. And if the tissue is healthy and you've debrided it and lavaged it and you're confident in your tissue plane health, then placing a couple of sutures, reattaching subq together, or reattaching subq with some tacking sutures down to the fascial layer of the muscle below it, is a great way, and probably the best way, to control dead space. Sometimes we don't have that option, and keeping all that wound fluid in there can lead to a lot of problems. Also, high motion areas where normally there's some version of dead space, but now we've got a traumatic insult that led to excessive tissue fluid production, and they're going to collect in places like the neck or the axilla or the inguinal region. Sometimes those are reasons why we may place a drain, just to cut down on that fluid production over the first few days that a wound is starting to heal. And then the question of where, and there really is not a wrong place, if you will, to place a drain. It's just, do we need it? And when we're talking about surgical wound drains, we're talking about placing a drain sometimes between the skin and the subcutaneous tissue. More often, we're looking at the subcutaneous tissue plane between that and the muscle and or body wall. So the different parts of the body where we may place a drain, I think in general, again, they're independent from why we're using it. I try to stay away from using drains on the limb because we usually don't have to. Again, bandaging techniques, if it's on an area of the limb that's readily bandaged with a compression wrap, I'd much rather use that than placing any type of drain. And there's examples here in these pictures of what we call open passive drains, like a Penrose, and then a closed suction drain, which is the other picture here with the silicone tube and the blue suture finger trap on it. And we'll talk about the differences between these two and the pros and cons of each. And although this may seem, elementary or simple, I think it's a really important topic, is how do we even place these drains? And if we have that first priority in our mind, what is our goal here? Our goal is to minimize dead space. And if we just have that as our single goal in mind, then I think we do a really good job of how do we place them, where do we place them? We answer the whys because we're trying to control dead space, because there's a major risk benefit. We have to decide if the risk of fluid accumulation is better than or less significant than all of the risks of a surgical wound drain. And if we can come to a consensus inside of ourselves when we're making that decision in surgery or in the emergency room or in our practice where we're looking at these wounds and trying to decide what we should and shouldn't do, I think we'll come to the right answer for that patient at that particular time. Again, our number one priority, and really our only priority, is to minimize dead space. So if you can ask yourself that question, you'll probably be able to answer whether or not that patient should receive a drain or not. Dead space can be painful in certain areas of the body. It can put some tension on your healing incision, which can lead to dehiscence. Although we always worry about dead space and infection, I think that's a very low risk if we have completely devitalized tissue and infected tissue that we've removed. If we haven't, and we know that we haven't, one of the worst things that we can do is place a drain in that particular wound. We already have an area or a wound bed that is less resistant to infection. The number of bacteria required to induce infection around devitalized tissue or already infected tissue is a lot less. And then we place a drain or a foreign material into that. We're decreasing tenfold or 100-fold the number of bacteria needed to set up and cause an infection. So it's not so much that seromas lead to infection, it's that if we're using a drain to drain an infected area intentionally, then we know we're going to run into a problem. Or if we close a wound that we know has infected tissue in it or devitalized tissue, the seroma that forms will be a great nutrient base for those bacteria. Drains, foreign body, they lead to lots of inflammation, even the bioinert ones or less inflammatory ones, which again, will lower the tissue's adaptability or ability to handle bacteria, so easier to induce infection. The inflammation can cause dehiscence. It's a foreign body reaction. It can be uncomfortable. So there's a pro and con list here. By definition, if we just look at a seroma, it's just a pocket of serous and sometimes serosanguinous fluid forming between tissue planes that otherwise would be opposed. And they continue to allow for that separation, which means it takes longer for those to heal. And it can be a source of bacterial colonization, again, if we already have devitalized and or infected tissue in that wound bed. So there is a potential infection risk there that's important. Drains, foreign material. In some studies of clean wounds, which I'll show some examples of, some surgically induced wounds, for instance, in those particular wounds, we can use a drain and have it reduce the number of bacteria required to induce an infection in a clean wound by 10,000 times. And that's why, for the most part, we try to avoid drains in clean surgical wounds. You're taking off a mast cell tumor or a sarcoma somewhere. We really want to try to avoid drains in those cases because of the high likelihood that an infection will ensue. So when we look at the idea of open versus closed, a pretty simple classification system for the different types of drains. I'd like to keep this simple because I think we all think along these lines is the difference between the two. It really has to do with the open versus closed classification, how we place them, where we place them, how do they work, how long do we keep them in, and some of those questions get answered pretty quickly here. These open passive drains, just think Penrose drains. There's nothing really working or pumping or pulling fluid out. They, in general, work by capillary action. There's also some mechanical action. Let's say the drain is over the abdomen or the thorax, and as inspiration and exhalation are occurring, we can move fluid in and out. But overall, these open passive drains are just that. They're gravity dependent or capillary action based. And we have to, again, remember that when we're placing these drains, and it can be hard to remember sometimes when your patient's under a bunch of drapes, you can't see the head, you forget where the feet are, and what's dorsal, what's ventral, what's gravity dependent, what's not. I've certainly made that mistake where I've pulled all the surgical drapes off and realized that I placed the drain in the least gravity dependent portion of the body and have to redo it. There's no point in using an open passive drain and not have it be exiting at the most gravity dependent part of that wound or that body plane. Again, if our whole goal is to decrease fluid accumulation to prevent dead space formation, then we better place them correctly. I think another way to look at this is that all open drains by nature are passive, and really relying on gravity in most cases to keep fluid from accumulating in that wound. And they're surface area dependent. So the more surface area that drain exposes to the tissue beds and to where the potential fluid's going to form, the better they work. And really the difference between using them in clean or clean contaminated, I've already mentioned, we really don't want to be using these types of drain in clean wounds. In general, I wouldn't put these any deeper than the subQ layer. These are great if you're going to use them between skin and subQ. I think there are better options and more appropriate options if we're using them deep to the subcutaneous tissue. So between the subQ and the fascia or the muscle below. Drains in general, when we're talking about surgical wound drains, they are supposed to be short-term use. You cross that point of where these drains are producing as much fluid as the wound will by itself, and now you're stimulating so much more inflammation. So when I say short-term, Penrose drains, really there's no need to use a Penrose drain more than 4 to 8 hours. And that may come as a surprise to a lot of us, but if you think about what you're trying to accomplish and what you're trying to avoid, if you need to use it for longer than that, we probably didn't remove all of the tissue that should have been removed on our first surgery, from regardless of what the trauma is. At some point, again, you're going to say, well, there's still a lot of fluid being produced here, and it's for one of two reasons. Either the drain is inciting that type of fluid production from inflammation, or we missed something in the surgery. So we really shouldn't need a Penrose drain in for any longer than 4 to 8 hours. There are chances of causing problems in that case skyrocket after that 36 to 48 hour mark. Anything that's open and passive, and in fact, any drain that has an entry and or exit point should always be covered. If we're trying to keep fluid out of the wound because fluid is a nice medium for bacterial growth, we have an open hole or an exit hole, even if we've sutured it, that's a great place for bacteria to ascend. So we want to keep that covered. Plus it collects the wound fluid instead of it dripping all over the hospital or all over the pet owner's house. So again, this idea of functional drainage, it is passive and it really can have some capillary action. And if we look at that, there's a lot of advantages of using these types of drains. They're inexpensive, they're easy to place. We don't have to have any special equipment or training. So there's probably always going to be a place for things like Penrose drains, but I think we have to be careful of why we're placing them, when we choose to place them, where we place them, how we manage them by keeping them covered into a sterile bandage material that is absorptive in some way. And to summarize the disadvantages, a very intense stimulation of inflammation, decreasing the number of bacteria required to induce infection, dehiscence, sometimes discomfort, and they're uncovered. They're creating an exit hole or an entry hole or both, and we'll talk about some of the pros and cons of that. But we really have a situation here where we can make things a lot worse. So never place a Penrose, because they're so pro-inflammatory, directly under a skin incision, meaning don't have it tracking between the skin and the subcutaneous layer, because the inflammation there, you're going to run a risk of dehiscence just from that alone. Doesn't mean it can't cross the incision, doesn't mean it can't go deeper to those layers. You really just don't want it right under the skin. I see a lot of Penrose drains exiting in fur. You know, the skin's dirty enough as it is. Even chlorhexidine scrubs used appropriately still cannot get rid of 30% of the skin bacteria that are living in fur follicles. So we really have to make sure that we minimize the risk of ascending infection. Don't have the drain exit through the middle of the incision, which goes along with not having the drain under the incision. Again, tremendous amount of inflammation. And we really should have them protected at all times. I mentioned open passive drains, again, Penrose drains being one of them, really depend on surface area. They work the best when their surface area is the largest. Penrose drains and other drains like them don't drain through the center of the tube. They drain through more of a capillary action, and so it's all surface area dependent. And I only bring this up because sometimes I have seen in lectures or even in clinical use that little tiny fenestrations or holes are cut in the Penrose drain. And that idea would be that if the drain was being used because it's pulling fluid into the center part of the drain, it's a tube, but that's not how they work. You're actually decreasing the surface area of a Penrose drain if you cut fenestrations or holes in it. So we don't need that and we don't want it. We want to keep that Penrose drain intact, again, which keeps the surface area as high as possible. The one thing I will say, and hopefully I'm not offending anybody, but again, we want to minimize the number of holes entering a wound. And so Penrose drains should not be placed through an open and an exit wound. There shouldn't be a drain sticking out above and below the wound. We want to minimize that as much as possible for all the reasons we just discussed. So we want to have a single exit hole. We want that hole to be gravity dependent. We want that hole to be away from the incision and try to keep the drain away from running completely underneath the skin incision. And so there's a lot of ways to do this, but taking a hemostat or a Carmalt and grasping the drain, leaving a little bit of extra outside the Carmalt, putting it to the most dorsal aspect or the least gravity dependent portion of the wound, and then grabbing it percutaneously with a needle and suture, where we'll tack it in place there. That's really, if we're going to use these open passive drains, the ideal placement. I know sometimes it can seem like it's a lot easier to make a big hole up top and have drains sticking out at the top, and then of course drains sticking out of the bottom. But this is really the best way, the safest way to use a drain. So this is a really well-placed drain. That suture on the skin dorsally is keeping the drain intact. And so when we go to remove the drain, we cut that suture first, and then we'll cut the suture that is attaching the drain at the exit hole to the skin, far away from the incision, gravity dependent. It's a really nice placement. The only thing we'll do here is cover that drain when that patient wakes up. I'm not sure where all this comes from, but using drains in wounds that are already open is just not a good idea with all the extra inflammation that's being caused. It's going to make that wound bed look a lot worse. Plus the wound's open, so it's draining. I'd rather just have an open wound draining on its own than add a bunch of foreign material to it. And then there's, using a drain as a mechanism by which we can flush saline or chlorhexidine or antibiotics into a wound completely defeats the purpose of a drain. We never want to flush anything into a drain because the whole goal of using the drain is to minimize dead space, which if we're flushing something into the entry hole, we're increasing the amount of fluid and increasing the amount of dead space. So I don't know how much that happens anymore. I used to hear about it and see it a lot, and I think a lot of us realize now our whole goal is to minimize fluid. And I already mentioned it, but I try to have a single exit point and not an entry point and exit point for the reasons we just discussed. The risk of bacterial infection ascending or descending in this case into these wounds is very high, and we want to minimize the number of holes that are existing in these patients. And like I said, we always want to avoid the incision too. We want it far away, gravity dependent. We don't want it exiting through the incision or exiting in furred skin. Yeah, I mean, this is a wound again. It's another bad skin avulsion case. After we get the leaves and the flowers and the dirt out of this and we clean it up and debride it and lavage it, there's a lot of dead space there. It's a massive amount of dead space created by the skin avulsion. We're going to use a drain here as long as this person puts on a pair of gloves while they're handling this dog with a giant open wound. So now we've got gloves on. That looks great. And we're going to have a little exit wound here. We're going to use that technique where the Penrose drain at the non-gravity dependent portion is being held by a hemostat. and grabbed through the skin. You can also take a bite with your needle from healthy skin into the wound and grab it, then bite through your Penrose drain, and then bite back up through the skin. So it doesn't have to be like a Marco Polo game here, trying to catch the Penrose drain with a needle when it's already in the wound. So let's talk about closed suction drains. There are a lot of pros or benefits of using a closed suction drain over an open passive drain. They're just a little bit easier to manage. You don't have to place them in a gravity dependent area, but it doesn't mean they're not free of all of the same risks that open passive drains are. They really do help facilitate drainage because they're employing some version of suction. And again, the goal is the same. We want to eliminate dead space. And closed suction drains in general are better than open passive drains for tissue apposition. So if we think minimize dead space, let's get these tissues apposed as quickly as possible, then yeah, closed suction drain is going to be better at that in general. It does limit bacterial ascension because it doesn't have this big open wound with fluid dripping out of it for bacteria to, swim upstream, but it's still a small wound. This tube still exits the skin, and we suture it to itself and to the drain. We secure it, but it doesn't mean it shouldn't be covered. And so these entry points or exit points should always be covered regardless of the drain that we're using. Again, same goal. Let's eliminate dead space. If we look at some of the commercial closed suction drains, just a little anatomy lesson of the drain itself. A lot of the drains empty into what are called grenades, and the grenades are rechargeable. So you squeeze the grenade, it gets all the air out. You put the port, you lock it in place, and it is putting a negative of pressure onto the drainage tubing and into the wound as long as that wound's completely closed. And that's slowly applying some vacuum pressure and giving a place for that wound fluid to go. And because it's that, low level negative pressure, those tissue planes should be sticking together or sealing together faster. There are many different types of these closed suction drains. The ones that are on the bottom here of the 3-picture column, those are more typical of our Jackson Pratt drains. They're flat, they're multi-fenestrated. The big picture here are the ones that I really like, these T-fluted or Blake drains. Those flutes run the length of the drain material that's actually in the wound or in the abdomen, and they tend to clog a lot less. You can imagine all those holes getting clogged up in these other drains with omentum or very viscous or thick materials. That's why I like the T-fluted drains. There's not a right or a wrong here. There's not one drain that causes less problems or less inflammation or is more comfortable, but they are drains that I typically use are these Blake drains or T-fluted drains. If you place a lot of drains, I find it very convenient to buy the drain tubing on a trocar, and that trocar tapers to the diameter of the drain. So the hole that you make in the skin is an exit hole, isn't a giant hole that you have to put a lot of suture in. Very sharp trocar point, so you place the drain using the trocar from the inside of the wound to the outside of the wound. Again, does not have to be gravity dependent. If it can be gravity dependent, I'd still rather have that. Let's say for some reason your vacuum or your grenade's not working great, at least you still have a gravity dependent mechanism for fluid to leave the wound bed. You don't have to place it gravity dependent. That's why these are very convenient to use. Again, indications: minimize dead space, provide tissue apposition. It does not remove our potential issues of foreign body reaction, still causes inflammation along an incision. For a while, we were using these as having some diagnostic potential where we could take the fluid out of these grenades and look at it under a microscope or run glucose and lactates on it to see if we were dealing with the septic situation and how the cell types were changing. What we've now realized is that it doesn't really give you that much information at all. It actually can be very misleading, as glucose and lactate levels are going to change abruptly once the fluid's been sitting in this grenade for a little while, or even within the tubing connecting to the grenade because of the cells in there that are already utilizing glucose without access to more and creating a lot of lactate. Same with bacteria. You may find there's a lot of bacteria, even intracellular bacteria, sitting in the fluid in these grenades and in the tubes, but it doesn't necessarily mean that that's what's happening in the inside of the wound. So not all that helpful. The diagnostic potential is more of measuring volume, getting an idea of how much volume per hour these wounds are producing. These types of drains, they'll produce about 1 to 2 mils per kg on their own if they're just left in a wound. And so there's not a point where you're going to make no wound fluid because you have a foreign body sitting in your wound bed that will continue to stimulate wound fluid. So if you're measuring this and you're at 4 to 5 mils per kg and it heads down to 1 to 2 and the next day it's 1 to 2, you probably should have just removed the drain. And so this is no different um, from a utility perspective than Penrose drains. I don't need to use these drains for more than 2 or 3 days. If I am using it for more than 2 to 3 days, something is wrong or I didn't do a good enough job in my wound cleaning it up. Now, this is a different conversation maybe for the abdomen, but for surgical wound drains, these do not need to stay in place very long. And if I feel like they're producing a ton more fluid or a lot of fluid from the beginning, I may need to open that back up and deal with the tissue that I left behind that's probably not very healthy. A little bit different situation here with Penrose drains. We talked about surface area. With closed suction drains, fanning equation, flow velocity, maybe even Bernoulli's principle. The goal here is that if we increase the radius of the tube and we decrease the length of the tube, we're going to have a much better flow of fluid. Obviously, we don't want to put too wide of a tube in a Chihuahua, but we also don't want to use a teeny little diameter tube in a Great Dane. So having different sizes is really important. But you can see from the equation, the radius becomes the most powerful part of making sure things flow well. Now, length is important too, because you can cut these as short as you want as they exit the body. So the shorter we keep these drain tube lengths, the better this will drain over time. Lots of different ways to place these. If you don't have a trocar tip drain, that's okay. You can take a hemostat or a Carmalt, enter the wound, go to a place in the skin where you're going to want it to exit. I incise usually with like a 15 blade or an 11 blade right over the tips of the hemostat. And you'll go ahead and place that tip of that hemostat through the skin. I oftentimes actually will just grab another tip of another hemostat just to run it back through into the wound. And then I will grab with that hemostat or Carmalt or Kelly or Cryo the edge of the drain tubing, and I'll pull that through the skin. And as I pull that through the skin, the actual drainage portion, again, whether it's fenestrated or T-fluted, will wind up sitting in my wound bed. And once it's in there, you want to always make sure, obviously, all your fenestrations or your holes or your T-flute stay within the wound. If they exit through the skin at all, you're never going to get any negative suction on your containing device. And then I secure the drain to the skin at the exit hole. I'll use some suture there. Doesn't really matter what kind. I'll usually use like a 3/0 nylon. Take some bites as a purse string around the exit hole. I actually stay pretty close to the skin edge. And then I tie that tight so it's nice and secure. Again, this is all on the outside of the wound. We don't want to do it on the inside because then we'd have to go back to surgery just to undo the suture to pull the drain. This is externally. And then I go right into a finger trap pattern to secure that drain. So the finger trap, if you're not familiar or used to placing them, I place a 1 throw or 2 throws, and then I wrap each end of the suture around the drain and then tie it again. So you can see the knots are all on the same side of the drain. And it's a typical finger trap like we played with when we were kids, or if you have kids now, you're still playing with them, where you try to pull this away from each other, pull the drain out of the skin, and it makes the suture tighter on the tube. And so that's a very effective way of securing these in place. A lot of times I'll actually, right above the finger trap, I'll actually take another encircling suture and just tack it again to the skin just to make sure it doesn't get pulled out accidentally. So when we look at some of the studies just evaluating active suction wound drains in dogs and cats, this is where we find that in clean surgeries, so elective orthopedics, mass removals, these drains induce a very high rate of infection, which makes a lot of sense. You're taking a completely clean wound and you're reducing the number of bacteria that are needed to cause an infection by 10,000-fold. No wonder we're going to see higher infection rates using these drains in clean surgeries, not clean contaminated, not dirty or contaminated. So I almost always avoid placing drains in even these large mass removals. I don't want to take a large mass off, have this really large incision, and then create a perfect environment because I've placed foreign material in here for even the skin bacteria to get in and lead to a giant abscess. So
try to stay away from drains of any kind, closed suction or open passive, in a clean surgical wound. One of the things that I really had always wondered was, you have all these different grenade-like devices, these squares, these bags of grenades, and are any of them really effective over time? And what we have found is that the grenade drains, which most of the time we actually use in veterinary medicine, so we are really ahead of the game from the human medicine side, are really the best option we have. They're the safest, and they are the ones that work the longest. Even after 24 hours, that grenade is no longer as effective as it was. So by the time you get out to 48 hours, it's not really acting as a closed suction drain anymore. And so if you need to leave it in longer, probably something wrong with your wound, but it may also be the reason why I try to still place it gravity dependent, so at least it can still drain in that way. But at 48 hours, these drains are really not all that effective anymore. And so that's why the short-term use is another reason why it's really important. And this was just the publication, if you're interested in why, at least for abdominal drains and true of wound drains, using lactate and glucose and even cytology to determine what's happening in the abdomen or in the wound really aren't that useful at all. So in general, grenade type closed suction drains, they're safe. They're probably the safest type of closed suction drain that we can use. They really have this very predictable low level of suction. Some of these other vacuum generating devices produce a higher level of suction, which can erode arteries and veins and cause actual tissue damage beyond just the inflammation from the foreign body. And overall, they have a minimal effect on fluid production. You can expect any drain, even a grenade type closed suction silastic tubing drain, to produce 1 to 2 mils per kg of body fluid in a 24-hour period. So it's never going to reach zero. And if it reaches zero, your drain's probably plugged anyway. And again, just another reason why, we really don't need to use these for more than 2, maybe 3 days, even these closed suction drains. There are some examples when the heart and the lungs are showing that we're going to need some serious drainage of many different types. So no real take-home point here other than just a great picture. I've shown this picture in many wound-like presentations because this is a situation where you have this great example of having missed some foreign material and devitalized tissue, and what happens when you close it, and more dead tissue begets more dead tissue, and you wind up with a massive wound resection. And this is a version of delayed primary closure. We are managing this wound open until it looks healthy enough. There's that big, beautiful granulation bed that's inherently resistant to infection. And then we're going to close it. And when we close it, again, we know we have a lot of dead space here. And so using drains in this situation to help the tissue planes reoppose themselves, they've been open for so long, they need the help of this drain by limiting seroma formation. One of the things I love to talk about in veterinary medicine is we're all very creative, and we have to be. And so these do-it-yourself closed suction drains, many of you probably already do this, but there's 2 different types of closed suction drains. They just use different types of materials. For the first one, you really just need a vacutainer or a series of vacutainers. I use the biggest butterfly catheter I have. If it's a 19 gauge, it's great. Anything smaller than that, the 20 gauge, 25 gauge, probably not worth using in this case. And I use one of the other types of the do-it-yourself drains, and some nylon. And if you take your butterfly catheter, you're going to cut off the female end, the adapter end, and you're going to throw that away. And what you're going to do with your butterfly catheter is the exposed tip now, where you removed the female end of the hub, is you're going to cut little fenestrations in that tube. That's going to be what sits in the wound itself. And I learned this the hard way, but when you're creating fenestrations in an already small tubing material, count your fenestrations and write them in the medical record. Because as you go to remove this thing and there's only 3 fenestrations and you can't remember, like me, 2 or 3 days ago when you placed it, you may have left some tubing behind, which is clearly going to cause some problems down the road. So I always count my fenestrations and I write it in the medical record. And this will be your final setup. Obviously, the big picture there is not within the wound. It's just for example. But as your tissues are sealed, those fenestrations and the tip of that butterfly catheter will be in your wound, and you'll put the butterfly catheter needle into a vacutainer, and it will begin to apply low-level suction to your wound bed and pull fluid out. And then when your vacutainer is full, you can pop another one on. And so these are very useful in small patients, but also in areas of the body where you don't want a seroma to form. You want to oppose tissue planes, but you don't need a giant Jackson Pratt drain or T-fluted or Blake drain. The ear is a good example. The foot's a good example. In this case, this was in a wound in the, down towards the tarsus and metatarsal area. Not a lot of room there for big drain devices. So just exits the skin, just like we talked about how we would place another closed suction drain without a tapering trocar tip on it. And it's exiting that little exit hole, and the vacutainer will be set up in there. The fenestrations are cut and in the wound bed. And then, they're very easy to attach the vacutainer with some tape. And as that fills up, take the tape off, get rid of the vacutainer, and put a new one on. The other way, which I actually seem to prefer and do more often, because I can, instead of being limited by the size of the vacutainer, I'm now limited by the size of the syringe that I'm using. And typically you're going to use a 10 to 20 cc syringe. We don't want a 60 cc syringe because the amount of negative pressure that can apply is a lot more than what we really want or need. And then just some IV tubing extension set in an 18 gauge needle or bobby pins. And all we're doing here is we're taking the IV extension tubing, we're cutting off the male end this time and getting rid of that. We're leaving the female end, and we're cutting our fenestrations in the part of the tube that is going to go into the patient or stay in the patient's wound. Count your fenestrations. And then we're going to connect a syringe to the female end. And we're going to pull back on that syringe once the tube is in the wound and the wound is closed. And then we can, with the 18 gauge needle, we've made a little hole in the plunger, and we can either use a bobby pin to keep it there or any other type of holding mechanism. And that's, again, there's your negative, constant, low pressure being applied to a wound bed. So they both work. I tend to use this one more often than the other. I can use a three-way stopcock if I want to take the syringe off, put a new syringe on, and continue to manage that wound in that way. There are some reports of using closed suction drains to treat oral hematomas. I only put it up here because it's information that's out there. I think prednisone works pretty darn good for most of these cases. Complications we've already talked about. Just to summarize them, they do increase wound infection rates, especially in clean surgical wounds. So I try never to use these in clean surgical wounds. They increase complication rates, and closed suction drains in general help reduce some of them, but they're not without their own risks and problems. And sampling we don't really need to do. This is just an example of I'll call it a complication in a closed suction drain. This is just a giant fibrin clot that plugged up the entire tubing. Again, no point in using the drain if it's not able to drain. The uncovering and keeping these drains uncovered is, I think, a big problem. I see it even in our specialty hospitals and universities, these dogs walking around with their drains exposed. They're laying on the floor. People are petting them, with no gloves on. We're really asking for some major complications in a lot of these cases, especially with the multi-drug resistant organisms now that live in the veterinary world. The other thing too is if these drains are just leaking fluid out onto the skin, we do see some very severe fluid maceration induced skin disease because of these drains being uncovered and not having something absorptive collecting that fluid. Yeah, this is one of my cases. Yes, it's drain abuse. There's a lot of Penrose drains. Some of them are entering and exiting. Some of them were placed in a non-gravity dependent fashion, which is really doesn't make any sense, but I've been guilty of it too. Again, you take the drapes off and realize you thought the dog was facing the other way. And those are drains that don't need to stay in that dog. They're going to cause more harm than good. And this is a great example of just in my head, because this is one of my cases, thinking, yeah, there's still a little bit of divinalized tissue in there, but it doesn't look too bad. And we'll just pop a drain in after a little debridement and be okay. Dead tissue begets dead tissue. So we've got to do a good job in making sure we do the best we can surgically, that drains are not a replacement for surgical debridement and lavage. Again, no need to place drains in wounds that you are intending to keep open. An open wound is the best form of drainage we could ever hope for. I know it's really convenient, but that entry wound, exit wound, and then tying a drain in the knot, again, very fast, no suture material, but I don't think it's worth the risk of having an entry and an exit hole. I'd rather just suture this in place and take the extra time to do so. Another dog that it looks like a porcupine. Almost all of the drains are dorsal instead of ventral, and that's what interns are good for. They give you opportunities to take some really great pictures, and that's a case that needed those drains pulled and have them placed appropriately. Make sure we pick the right kind of drain if we're going to use them. Make sure we're placing it appropriately, gravity dependent or not, and then make sure we keep them covered and manage them appropriately. Just be very cautious and question yourself. If you're thinking about putting a drain in, is your only goal of putting that in at that moment in time in that patient truly just to minimize dead space? If there's more to it than that, I would consider not placing the drain. I would consider cleaning up whatever tissues are left behind that you're worried about before placing a drain. The simple solution is the delayed primary closure. If you're not really sure, leave the wound open for a day or two. Those tissues will tell you, they will communicate it very loud and clear if it's ready to be closed or not in a 24 to 48 hour period. And you may not need a drain at that point. So it's worth doing and practicing delayed primary closure. We do run the risk of ascending bacterial infection regardless of the type of drain that we're using. There's a hole in the skin. Even if we've sutured it closed, the bacteria are pretty small, and they all cause foreign body reactions, and they will all increase wound fluid production. Obviously, discomfort and dehiscence, all the things that we've talked about are reasons to be very cautious anytime we are choosing to use a drain for a surgical wound or a traumatic wound, and we just have to be careful about that. Again, the idea that the best form of drainage is when in doubt, place a drain should really be transformed into the best form of drainage is when in doubt, leave it open. There's not a better form of drainage than leaving the wound open until it's ready to be closed. This is just to remind me that Penrose drains are radio opaque. Every time I have a Penrose drain in a patient and it was removed prematurely by the dog or the owner, I always take a radiograph. Even though it looks like all the drains have been removed, the edges are nice and clean cut, always take a radiograph. If there's drain left behind, you will see it on radiographs. This is a case that had bite wounds and had a drain placed years prior to this x-ray. The dog had been living with these opening and closing fistulous tracts up and down its thoracic and lumbar spine, all over the skin. And once an x-ray was taken, a radiograph was taken, you could see the Penrose drain sitting there, sitting roughly over like L3, maybe L4, and then performing a fistulogram, injecting contrast agent iohexol into these little fistulas and seeing it all directly communicates with that Penrose drain. So if it's ripped out or removed prematurely, just make sure you can convince that pet owner to bring the dog in so that you can just take an x-ray, because these things do lead to some major issues down the road. Just another case, old traumatic wound years prior to this radiograph. The dog came in for acute limping. Actually, we're suspicious of osteosarcoma because of the amount of swelling and pain in the proximal humerus. And it had a Penrose drain just sitting in there for a long time that decided to cause a pretty severe tissue reaction and pain years later. So that was much better than osteosarcoma. So we should be using these to manage dead space, and that's really it. It's not an alternative to surgery or antibiotics or any other type of management of open wounds that we decide to close. It should only be to oppose tissue planes by minimizing dead space and fluid. Have to think about the type of drain, the type of material. I think keeping all drains covered is important, and leave them in as short a time as possible. So with that, I hope everybody enjoyed the webinar. If you have any questions, please type them into the question box and I will happily get back to you with answers. And we look forward to seeing everybody or talking with everybody on the next continuing education webinar.